Good morning. I'd like to first thank Dr. Scaglione and Dr. Ricchito for giving the opportunity to speak at this program. The agenda looks terrific, and I'm honored to be part of it. I'm going to be presenting specifically in sports cardiology and the impact of cardiac medications for athletes. First, I'd like to start because new to Northwell is our sports cardiology program, recently launched. So I just want to take 1 second to touch on what is sports cardiology. It is certainly a growing field where there's certainly not a big footprint on Long Island. In fact, we'd be the first formal program on Long Island. So what do we do in sports cardiology? So there's really 4 big buckets, and this is a slide from Aaron Bagish, who's up at Mass General, who's sort of in the forefront of this field. So the 4 big buckets, very briefly, are number 1, differentiating what's called exercise-induced cardiac remodeling from cardiovascular pathology. I think we're familiar that as we get more highly trained, the heart undergoes certain physiologic changes in order to adapt to that stressor. But it often becomes very important to try to discern between what is a normal physiologic adaptation versus a pathologic change in the heart function or structure. The other thing we do is evaluate the symptomatic athletes. Just for definitions, CAHAP here refers to a competitive athlete or highly active person. So somebody who is, say, an avid runner who notes that they don't have the same exertional tolerance that they had previously, that is someone that we would evaluate. The other bucket is the management of competitive athletes and highly active people who have pre-existing coronary artery disease. How can we ensure it is safe to continue participating in activity? And then the 4th bucket is a collaborative pre-participation cardiovascular screening, which I'd also call some of our community work, which is outreach into the high schools and the colleges and professional sports team to assure adequate cardiovascular risk stratification before sport. I think also in this bucket, and slightly new, is sort of the evaluation post-COVID infection and how to ensure safe return to play. So in the spirit of this program, I was asked to focus on the impact of medications on the athlete. And I think there's basically 2 guiding principles from a sports cardiology standpoint when it comes to medications and athletes. Number 1 is, will the medication impact performance? And number 2 is it a banned substance? And this is certainly more relevant to our collegiate and professional athletes. But it's an important thing to consider, as there are cardiovascular medicines that are quite common that may fall into this category. So what I'd like to do for this talk is focus on the 3 most common cardiovascular conditions that we see in our athletes. We'll give a quick high-level few points about each of these entities, how we treat them, the impact of those therapies, and then finally a quick one-liner on eligibility with these conditions. So we'll start with hypertension because this is the most common condition that we see in our athletes. Interestingly, they've done a cohort study among NFL athletes and have found that there is a prevalence approaching 13.8% of the players having hypertension when compared to 5.5% in an age-matched cohort. Obviously, there's a relationship between blood pressure and exercise in the sense that it is a physiological response to see your blood pressure increase as you increase exertion. However, what there's less known about is in certain types of exercise and in certain individuals, there may be an increase in blood pressure that is out of proportion from what you suspect. And we generally tend to see this in our athletes who have more static exercise. And again, for definition's sake, static exercise refers to more sort of isometric contraction, weightlifting, anything where the focus is on power, versus dynamic exercise, which tends to be more aerobic. So for a definition standpoint, For the diagnosis of blood pressure, you see I have two numbers here, 140/90, and then the recent guidelines, which have leaned to a slightly more aggressive definition of 130/80. One point on technique and how we measure, I think it's important when we're evaluating our athletes, because it may not be in an office visit, it may be at a stadium during a pre-participation physical, that we are measuring the blood pressures accurately. So that means we have to assure there was an adequate period of time where the athlete was sitting quietly and resting. That is not done over any clothing, and that the arm position is in the right way and fully supported. The athlete should not be holding their arm up, as that may add significant amount of points to the blood pressure number. Also important to note is that to diagnose high blood pressure, you would need two readings on two separate occasions that would be elevated. And also, what's coming to guidelines, if you suspect an athlete may have an elevated blood pressure, that there's role for ambulatory blood pressure monitoring, a 24-hour monitor, which may help break the tie. So just to dive a little deeper into the definition of blood pressure. So in the most recent guidelines, the American Heart Association, American College of Cardiology, there's something called stage 1 hypertension, which is the range stated on the slide. And obviously this will capture a lot more people, but essentially the indications are if you have a 10-year risk for cardiovascular disease that's less than 10%, then the focus will be on lifestyle modification, which certainly is around diet, salt intake reduction, and then for people particularly have a focus on a static type sport to increase the amount of dynamic or aerobic exercise that they're doing. And then stage 2 is the definition we're probably more familiar with, 140/90, at which point, in addition to lifestyle modification, medical therapy would be warranted. So as we look at our options for treatment, and this is the medication aspect of this, again, the first tenet of choosing an agent is choose the one that is least likely to impact the athlete's performance. So while the ACC/AHA guidelines will lay out for first-line therapy, you could choose dihydropyridine calcium channel blocker, an ACE or an ARB, or a diuretic. As we'll touch on below, diuretic would not be considered a first-line agent in an athlete. We would opt for vasodilators. Again, as listed here, dihydropyridine calcium channel blockers, which is amlodipine or nifedipine, or angiotensin receptor blockers or ACE inhibitors. And again, in the spirit of avoiding agents that impact performance, so diuretics obviously can lead to dehydration, decreased intravascular volume, which could certainly result in decrease in athletes' performance. And the other thing just to note, when we talked about is it a legal substance, is in some governing bodies, diuretics may be considered masking agents. So just something to be aware of. And then the other agent that's commonly used for blood pressure are beta blockers, but these have the potential for significant negative impact on performance. And then also in certain sports like archery, for example, they're considered banned because of the sort of calming effect that they'll have. As far as eligibility goes, even with the blood pressure 140/159/90 to 99, that would not exclude you from participation, but there should be obviously an aggressive focus on better blood pressure control. However, if the blood pressure is 160/100, that would exclude you from participation until blood pressure is better controlled. So the next disease state we'd like to touch on is atrial fibrillation, which is also fairly common in athletes. And the relationship between exercise and atrial fibrillation is quite complex and still an area of investigation. There's some prevailing theories of what might predispose an athlete to atrial fibrillation. Two of them, for example, is either a change in autonomic tone, as we see, our highly conditioned athletes tend to have a higher vagal tone, and the other possibility is some left atrial remodeling that may occur. And just to show you how sort of vast the data is, There's some reports that range, depending on the sport, from 0.8% to 26.5% of athletes developing atrial fibrillation. Again, that's depending on the type of sport. But what is suggested is that it's the longer duration of vigorous exercise, generally at least 10 years, with 3 vigorous sessions per week, is when we start to see the uptick in an incidence of atrial fibrillation. Interesting, this relationship in some studies has not been as pronounced in female athletes. When working up these patients, an athlete's workup is similar to a non-athlete workup, inclusive of echo, EKG, thyroid studies, and when appropriate to exclude sleep apnea. So the management of atrial fibrillation in an athlete poses a few hurdles because, again, the mainstays of therapy have a high risk for impacting athletes' performance. So one thing to note is if you've exercised to a point where you have atrial fibrillation, does additional continued exercise make things worse, or is there no additional impact? And it's quite unclear, although one thing that could be considered, and we have this topic is common in sports cardiology, is the concept of detraining, where you would back off the intensity of your exercise for a period of time and see if the atrial fibrillation gets better. If detraining is not an option or atrial fibrillation persists despite detraining, it's reasonable to start to consider pharmacologic interventions. And then same with the non-athlete population, there's 2 general pathways, rate control versus rhythm control. And I think if you have an athlete that has a relatively low burden of atrial fibrillation or low symptom burden, it's certainly reasonable to consider rate control with beta blockers or non-dihydropyridine calcium channel blockers. And again, just for clarity, those would be inclusive of diltiazem or verapamil. But again, important to note, as previously mentioned, beta blockers, as well as these particular types of calcium channel blockers, have the impact to impact performance in the athlete. If there's more persistent atrial fibrillation or symptoms that are more significant, it is reasonable to consider a rhythm control strategy. So how do we take the patient out of atrial fibrillation and keep them out? So the first line of therapy is antiarrhythmic therapy, and particularly in younger, healthier population, which I think would encompass a lot of our athletes. Class 1C antiarrhythmics are generally the agent of choice. And again, for reference, flecainide or propafenone are those medications. There's 2 ways to take these. One is steady state, meaning you take a standard dose and you stay on it. And the other option is something called pill in pocket, which means you would take a PRN for when symptoms develop. The only thing to note, while this is a good strategy to keep people out of AFib, they need to be taken with an AV nodal blocker, like the aforementioned beta blockers or non-dihydropyridine calcium channel blockers. So again, at least for while you need to take that, there may be an impact on performance. There are other options for antiarrhythmics, although generally not favored by the athletic population because they either require hospitalizations to initiate, like sotalol and dofetilide. Dronedarone is just not very effective. And amiodarone has a pretty unfavorable side effect profile, particularly for prolonged use. The other thing that comes up, which is just interesting to note, and there is not enough data on this, is antiarrhythmic medications always have a small potential to become proarrhythmic. So the potential proarrhythmic effects of these antiarrhythmics in a competitive athlete has not yet been identified, although there hasn't been anything clearly identified that has shown an adverse event from being on these medicines. One final thing to touch on, although it's not specifically a medication, it's just another intervention, is an ablative therapy. So it's certainly possible to undergo what's called pulmonary vein isolation, which is also an AFib ablation. And in studying athletes, they found a success rate comparable to the general population. with about 80 to 85% of athletes being free of AFib at 3 years. Of note, and this is similar to non-athletes, about 20 to 40% may require more than one procedure. Is there a theoretical impact to performance? Electrical isolation of pulmonary veins and ablative scarring in the left atrium may impact cardiorespiratory fitness. Although this hasn't bared out in small studies, because generally what we found is that athletes tend to inhibit their performance prior to the ablation, concerned about the impacts of AFib. So we actually see an increase in their exercise capacity after the ablation. The final point to touch on with atrial fibrillation is anticoagulation. And this is based on your risk for stroke with AFib calculated by a CHADS VAS score. Generally, in most competitive athletes who are younger, they would not get a CHADS VAS score high enough to indicate anticoagulation. But in our athletes that do require it, it would preclude them for sports where there's significant risk for collision. So certainly avoid contact sports. If that is not an option after shared decision making, there's consideration for Watchman, which is a left atrial appendage occlusion device that would then obviate the need for anticoagulation. And then moving into the final, and then one last point on eligibility is that atrial fibrillation rarely excludes people from participation, as long as the symptoms are tolerable from the athlete's standpoint and the athlete remains hemodynamically stable. Then the final disease state is coronary artery disease. And again, this is obviously more prevalent in our older athletes. It is the most common cause of exercise-related sudden cardiac death in athletes over 35 years old. And again, likely mediated by ventricular arrhythmias. I listed here a few potential mechanisms for that, which in the interest of time, we will skip. The management for CAD in an athlete is similar to the general population. If there's suspicion due to risk factors or symptoms, we could risk stratify with an exercise stress test or calcium artery score. And then the mainstay of therapies remain the same. Antiplatelets, which again, these on their own would not preclude participation in sport and should not have any impact on performance, although obviously there would be a tendency towards more bruising. The management of hypertension, which we've covered previously. I think the main agent in the management of coronary artery disease that has potential for impact is statins. So a patient who has a diagnosed coronary disease, we need to be aggressive in lipid-lowering strategies. But statins, number one, have the tendency to cause muscle aches, which may impact athlete performance. And also note, there may be a significantly increase in CPK release with exertion compared to the similar amount of activity not on a statin. So certain things that we would try to get patients on a statin is to challenge and re-challenge with different statins to see if we could find one with acceptable impact on performance. And if that's not an option, but the risk factors dictate, we'd consider alternatives like ezetimibe or PCSK9 inhibitors. And then one final fact or point on patients who've had myocardial infarctions, how do we get them back to sport? So dual antiplatelet therapies, as we stated previously, not an impact. Beta blockers become an important part of management. And again, the indication to continue this is shared decision-making, risk versus benefit with the patient, although would be recommended in the post-MI period. ACE and ARBs, which are generally well tolerated, as stated previously when we talked about blood pressure, and statins, as we just talked about. The recommendation would be refraining from competitive sports for 3 months. And then in the appropriate population, cardiac rehab is a reasonable way to build up exercise tolerance as you return to sport. And then when we finally want to assess if someone is ready to return to full activity, there are a few options. And just in the interest of time, we'll just focus on the last one, which is cardiopulmonary exercise testing, which is probably the best way to assess the impact of exercise, because getting a more direct measurement of oxygen uptake really helps us understand how much the athlete can perform, and also gives us some maybe more sensitive indicators of ischemic thresholds. And I think with that, I'll stop.